regional service officers for Gippsland Primary Health Network. Predominantly, I'm based in the Bass Coast South Gippsland region. Just a quick reminder to ensure that your microphone's on mute and your video is often unless instructed otherwise. Any questions can be directed by the chat section of Zoom. And webinar recordings, presentation documents, along with the evaluation survey link will be emailed post-event. Our presenters today are Rod Wilson and Chris Luff, who presented last meeting. They're the directors of Kpis, which are community-owned primary health enterprises which aims to support communities and non-for-profit organisations to develop and run their own health services. I thank you. I'm going to pass it over to Rod. There will be an opportunity for questions throughout the presentation and a discussion before we finish. Over to you, Rod.
Great. Okay, so I'll start with that historic opening. I presume you can hear me, so I think that's what happens in all Zoom meetings. So just by way of background, Chris and I have had extensive work, for those who don't know us, working in the primary health sector, in community health, and we do a lot of work for PHNs, and I've been a previous CEO of a Medicare local, and Chris has been a CFO of a number of primary health services. So, and yes, feel free to put stuff in the chat room as we go, and we'll interrupt the session because it's important that you ask the questions that are on your mind. So the agenda for today is going to recap a bit on what we did last time, talk about the notion of primary healthcare teams and why they're important, practical ways to use the Medicare benefit schedule and how it can be used effectively, primary care modelling, medical practice modelling, knowing your business operations. So just recapping session one, we talked about the primary health service overview, about the health system in Australia, which we have a very good health system, but you know, there are some gaps. And there are issues around the interface between state and Commonwealth and public and private funding. And part of that, we looked at primary health care in Gippsland. Chris lives in Gippsland and we've done a lot of work in Gippsland. We've probably spoken to a lot of private medical practices and to a lot of public health providers in Gippsland. So we've got a pretty good idea about the peculiar issues that Gippsland faces. And part of the problem in terms of the separation of funding is that the best practice service models in primary healthcare are about integrated care. So the high need patients, the high need clients really need a team care arrangement. And so the separation, the highly siloed funding formulas actually don't lend themselves to team care. So what we talk about a lot is how you create that team care. And so for people who are interested in doing more, how you might create a self-funded primary health service, what does it look like? How can Medicare benefit schedule be used effectively? And one of the things we say about Medicare, of course, is that it's an uncapped source of funding by and large for GPs. You don't have to apply for a grant to get Medicare funding. All you have to do is fill in a provider form, be a registered Medicare provider, and Chris will talk about that a bit later. So how do we develop the primary healthcare team? You know, what's the best practice primary healthcare team? Well, you know this stuff as well as we do, but quite often we fall short of being able to actually make it happen. So obviously GPs, allied health, mental health, other health promotion activities, stuff that addresses the social determinants of health. All of these things are part of a best practice primary healthcare team. And, you know, the important thing is they're very localised. So in your town, in your neighbourhood, where you go to get your primary health service, quite often they fall a long way short of having this best practice primary health team. And part of the role of the PHN, obviously, in all of this is helping you deliver that best practice primary health care team. So understanding MBS can help you get there. Obviously, either building a team around a medical practice or building a medical practice into your team are the options. Ideally, it'll be a one-stop shop because we know that those very high-risk clients, patients, really struggle to get from one service to the next service. So there's a lot of evidence to show that you know, people just really struggle to go from a GP to a dietitian, etc. They just don't get to that next point of service coordination, that next point of service delivery. So care management and coordination is essential, but ironically, of course, many public sector medical practices lose money, and we'll talk a bit about who in Gippsland is actually public sector providers are actually delivering medical services. So things like integrated care and utilisation of My Health Record to support continuity of care is very important. And concepts like funds pooling. So in a sense, the more diversified your revenue can be, the better the chance you've got of building this team. So, you know, getting money from disparate areas, Commonwealth, state, from the PHN, we'll talk about that in a second, is really quite important. That helps you put together the team. These are some of the things that the PHN fund. So, you know, again, historically, the public sector providers, community health and hospitals, etc., have been very good at accessing these resources. But the private sector medical practices, which are really the cornerstone of primary healthcare, have not been great at actually accessing these resources. So it's really important if you're operating a private medical practice, or anyone at all, is you actually sign up to get the tender notifications from the PHN and other sources. So the PHN is constantly putting out tenders for services. And sometimes it's very hard for an individual medical practice to take the time to submit for these services. And one of the things we've been talking about before we started this webinar is the options maybe for networks of medical practices to get together and do some joint tendering for some of these services. So, you know, there's opportunities there to think differently. Conversely, the other thing we're going to talk about quite a bit, Chris will get to in a minute, is the public sector are very bad at using Medicare. So you've got two sectors, the private medical practice sector that aren't good at accessing funding, grants, etc., from state or Commonwealth. And then you've got the public sector that aren't really good at doing Medicare. The reason why this is important is because it goes to the building of the team. You know, this is not just about, when we talk about the name of this seminar, which is Growing Primary Health Services, we're not that interested in how big your budget is. You know, that's not really our primary concern. Although having been a CEO of a few services, having a big budget is very helpful. But it is really about how do you build your team and how can you fill in, how can you use the multiplicity of funding options to build your team. So, you know, there are many options for building an MBS funded primary health services. You can do a heap of it as the private medical practices rely on it totally, or you can do a little bit, like a public sector provider, a community health service or a hospital might decide that they want to have a physiotherapist that they've got funding for but they would like to get they could use Medicare funding as a potential way of addressing a waiting list for that service. So if you're a public sector provider and you're only relying on public dollars, that funding grants that you receive, you're probably missing an opportunity to actually have your service become more responsive to the clients. Many of these, as you know, the local hospitals, the community health services, a lot of them have waiting lists for these services, whether in mental health or allied health. Using MBS actually gives you a way to add value to that service. And the addition of that, of course, is that allows you, from a public sector point of view, to integrate your services with a GP. And that's kind of gets to that best practice integrated care model. So there's a lot of reasons why the public sector should think about using MBS. And there's a lot of reasons why the private sector should think about getting grants, because it helps you build this best practice team. So, you know, you could do, a public sector provider could do a lot of things. They could start their own medical practice. We know from our work in Gippsland that there are areas maybe of population groups of 3,000 or 4,000 people in a town that have very few, have very little access to primary health services. So there's opportunities for public and private services to move into those areas and think about starting their own service there through MBS or use of other grants. But, you know, the degree to which you want to get into that depends on your risk appetite. And a lot of people have been, a lot of people have tried some of this stuff and has not been, it's been hard for them to do it. So, you know, it's not straightforward. The stuff about getting a Medicare provider number and adding it to your public health sector services is quite easy, and Chris will explain that shortly. So again, it addresses your public waiting list through MBS, but you must have a good intake system. And one of the things that we found in our work in Gippsland, particularly in the public sector, is when somebody rings to get a service at the local hospital or the community health service, they often don't get asked, are you eligible for a care plan from your GP? And in a sense, it's kind of, from their point of view, it's irrelevant because they don't have the Medicare provider number for their staff to allow them to meet that need anyway. So the way you manage your intake in the public sector is really critical. But no point having a good intake system if you haven't got the stuff that sits behind it. So we just want to talk for a bit about the average funding model for a GP practice. A lot of organisations are managing really complex funding formula. You know, the PHN funds stuff based on a funding formula, and the state government and all works on sort of throughput stuff, NDIS, My Aged Care, all of these things are really quite complicated funding formula. MBS is actually a lot easier than some of those. So some of the services in Gippsland are already using these Medicare and those that are listed there. There may be some others. But, you know, these organisations have got into this to meet a community need, obviously, but also to try and build their team, to create a more integrated team. So there are big benefits for the community, obviously the clients in these organisations doing this work, and we've worked with quite a few of them. And there's also big benefits for the organisation, because the organisation then starts to bridge the private-public span. It becomes a service for the whole community, because the average medical practice is a service for the whole community, whereas a lot of funded grants are highly targeted. So medical practice allows you to bridge that gap. Now, a lot of these organisations have also struggled to make these things work and remain viable, But, you know, over a lot of years, they've managed to do it. So that's a great thing for them. It's an even better thing for their community. So the benefits of operating a medical practice in a public health service or from a private medical practice being strongly connected to a public health service is it can address market failure. Medicare does not work well in many remote rural environments because it's a throughput-based funding formula. So, you know, you've got to figure out how to do it. It helps you to respond to community need, obviously, and importantly, that connection between a private medical practice and a public health provider helps you create that integrated and holistic care, bridges public and private, and it can be quite self-sustaining through MBS. If you get the funding formula, if you get the budget right, and Chris will talk about this in a minute, if you get the budget right, then you can actually break even or make money out of it. So, which is what the private sector medical practices do by and large. But also importantly, in a public sector environment, and if for private sector providers getting grants, it builds your management capacity and your knowledge. So you've got to be a good manager to manage this stuff. It's not straightforward. That's a really important thing, to have the skills to be able to do this stuff in a way that is self-sustaining and works well. So again, financing an average medical practice in areas like Gippsland can be totally self-funding. You can, a lot of people say, oh, I don't have the space to do this. Where am I going to put it? Da, 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 da. If you get your finance model right, then you can build your capital, your borrowings, whatever it might be, your leasing costs into your financial model. So getting your financial model is terribly important. So I'm not a big fan of the, and we hear this a lot. We heard this a lot in Gippsland of we don't have any space. Well, we don't have any space because we're not planning to think about how we get the space that we need to provide the service. And that's by and large a financial model. And the other thing is that some public health providers need to get some advice about operating a service like this, because there are issues around the Commonwealth legislation about using Medicare, etc. But those things can be sorted out. So we just don't want to give you advice and have you running off and doing something and then finding down the track you got yourself into trouble. I don't think you will, but you know, it's good to get some advice about that. So people say, what about, you know, bulk billing versus non-bulk billing? Well, that decision is important, but it's not a critical success factor. You can run a break-even service on bulk billing, or you can run a break-even service on a fee charging basis. So people often go, oh, you know, I can't make any money out of bulk billing, but, you know, the evidence is pretty clear. 87% of MBS items are actually the bulk billing rate. So someone's making money out of it somewhere. So yeah, there's, as I said, there's an opportunity to establish these services through these funding formula in underserviced areas. And you might be aware of areas in your catchment where you think, you know, we could do something in that space, in that area, that would better meet the needs of that community. So it's kind of, this session is kind of a challenge to you as well to go, well, can we actually do better in a particular spot? So have a think about that as we go. Now, I think I'm passing over to you, Chris, at this point. Is that right?
So if you can stop sharing.
I'll stop sharing. And Chris is going to talk through the way that the finances of a medical practice and allied health and mental health can work. Over to you, Chris.
Okay. Okay, so thanks, Rod. So my part of the presentation is probably going to be a lot more dreary than Rod's. It's more about figures. I know there's a lot of information on this slide, but it's just giving you an example of work that we've done in the past on developing models for a medical practice. As it shows there in this slide, and I know it's going to be quite small on your computer, but it's very hard. The more GPs you have, the easier it is for the medical practice to run. So as it's got there, even if you've got 3 full-time GPs, it's still, depending on your operations, it's going to make it very hard for that practice to still support all its operational costs and so forth. So as it's got there, it's showing a generic model which just helps, and then has a list of all the items that you need to have a think about when you're actually running your medical practice.
Chris, sorry to interrupt. You might be about to mention this, or you are about to mention this. The average GP turnover per EFT of GP in Australia is about 400,000. So that's how Chris got to those figures in the last slide. Sorry, Chris.
Yeah, so if we go back, sorry about that. I'll just go back to the previous slide. As it's got there, when you're looking at the GP consultation income, as Rod said, it's based on the figure of $4,000 per GP, and then depending on the arrangement with the GP then gets a percentage of that split based on the arrangement that they've got with regard to that medical practice. So with regard to the medical practice itself, as I've got there, for most people, it's the first encounter with the health system. So it's normally the first place that anybody goes. And in our previous session, we also mentioned that a person goes an average of 5.9 times. And if you're looking at Gippsland, it shows there too that ours varies as well from 4.5 to 6.5, depending on where you are located within your area. And medical practices have got a choice as to how they operate. As Rod said, they can either be fully bulk billing, they can be a mixture of bulk billing and a fee paying, or totally fee paying. It really depends on the practice itself as to how they operate. As we mentioned before, you can operate successfully under all models, but some areas may require a mixed model, and it really depends on your patient throughput as well. And even with a total fee paying model, the GP still has the right, or can actually elect to bulk bill that person. So the ultimate decision on whether or not somebody is bulk billed or not bulk billed is generally made by the GP themselves. As it's got there, you receive an additional payment if you're bulk billing for people under 16, or if they've got a concession card holder. The GP sees roughly 1,000 to 1,200 individuals a year. And if you're talking about, and if you extrapolate that to the number of presentations, and if they do an average of 6, as you can see there, they'd roughly do 6,000 presentations a year. And as we've mentioned before, they've got an annual turnover of between 400 and 450K per annum. And really, it does vary. And there will be people who are lower than that, and there'll be people that are more than that. And we'll talk about it a bit later, but it is, as we said, it's a throughput system. And also it's based on the patients and the ability of your patients also to pay. The other thing is that a medical practice is also localized and it's neighbourhood based. What that means is that you can generally draw a circle around a medical practice, and that's where the patients will come from. And also, a lot of times, if a GP does move from one practice to another, depending on their contractual arrangements, a lot of times that their patients would actually follow the GP. And we've noticed in a lot of areas of work that we've done with regard to looking at medical practices, and especially when people talk about they want to purchase a medical practice, a lot of the goodwill with regard to the medical practice is actually with the GP themselves. You might have, 5,000 patients, but if a GP leaves, then some of those patients may decide to go somewhere else because they were really happy with their GP, or they want or they follow the GP to another practice. And this is just information on when you're looking at developing modelling. As we said there, they can either work or they can't work. So the main thing is that there are some parameters which you put around when you develop a medical practice, and it's just got some of the things that you'd be looking at doing. The number of support staff that you'd need for a GP, as it's got there, it's 1.4, administration staff. And the reason why there's variances in these numbers, it really depends on the size. Generally, the larger the medical practice, the less support staff you need to operate that practice. The other thing you need to have a look at is your overheads and how they've been generated and what they are. And as it's got there, the majority of people that come to see a GP, 70% of those are just for general type consultations. When you're looking at developing a medical practice, and there's a lot of things that you need to have a think about. So as we've got there, you need to look at the contracting arrangements with the GP. So in most instances, GPs receive a split of their fees, but there are instances in some organisations where the GP might be a salaried staff member. So you need to have a think about how that GP is employed. The other one is, as we've mentioned there, that the level of your staff is really important to make it work. That if you're looking at a larger practice, then you generally have a larger staff levels. What we've noticed is that even with one GP or two GPs, you still need a level of staffing, such as maybe half a nurse or a full-time nurse or a practice manager, and also reception. So that's where we said before that it's with the larger practices, they're able to absorb a lot of their operating and staffing costs because they're generating more revenue, but as a percentage of the number of GPs, it's a lot less than a smaller practice. That's why we mentioned before that often MBS, because it's a throughput-based system, it doesn't work that well in smaller practices because their overhead costs aren't really reflected in some of the payments that they receive. And we've mentioned before, you've got to decide as to how you charge your patients. And this is just an example, the next one, just an example of looking at what type of revenue might be generated. So as we've mentioned there, if you had 5 EFT of GPs, they generate between $2 million and $2.2 million, roughly. What you then say is that of that, 30 or 40% of that revenue might be available for operating costs, because the balance will actually go to the GP based on his or her contractual arrangements. So what you'd have to think about is, for your medical practice, is $600,000 enough to operate that practice? And that's when we were talking before, modelling is really important, and financial modelling is very important to make it work. The other things that we mentioned is that some medical practices do lose money, and when you're looking at metro and rural and remote, there are a lot of variances in how they work and throughput. So as an example, in Melbourne, in Metro Melbourne, if you're in the centre of Melbourne, you can charge probably $100 for a person to go to see the GP, because it'll be in the centre of the city, and that may be the only opportunity they have got. And also they've got a lot more throughput. So in a smaller remote area in Gippsland, and we have got a lot of areas, some areas have got a GP, but if you look at the modelling, the number of patients for that GP would be less than what would be required to sustain that medical practice. The other thing, as we mentioned before, is that because MBS is based on throughput, then that doesn't always suit more remote medical practices. The other one is there could be poor management, and that's to do with their operating costs and so forth. And market failure, that's where we've mentioned before that MBS is not, if you just looking at MBS as being the revenue contributor, it's not always the right level to go. So I'll give you an example. Is that if, for instance, a GP leaves an area, often that Mbs funding goes with the GP. It doesn't stay in that area. So therefore, if the practice is funded if it has got 2 GPs, why isn't it got some kind of guaranteed level of funding, Mbs funding, based on the fact that they always employ that level of staff? This is just a couple of other areas that when you're looking at medical practices, how you might be able to improve their revenue, and that's how they use the nurse. The practice nurses, for those that employ nurses, can be one of the most important people within our organisation to generate additional revenue. What they can do is that they can support the GP in doing the next 2 things: management plans, mental health plans, and health assessments. So they can help the practice do those. So take some time. So therefore, the GP would still be able to see patients, and the nurse will be able to do some of the preliminary work for those plans. The other thing that a lot of medical practices need to look at is the level of GP management plans and mental health plans that they have. They need to ensure that what they do is that they're within their client database, is that all those people who are accessible for a mental health plan or a GP management plan should have one. And the other area related to that is also to ensure that the recalls for those plans are undertaken. Health assessments, and that's one area we've noticed when I've done a lot of modelling of medical practices, that if you looked at all the people who are over 75 years of age who can have a health assessment, and also other people who meet the criteria, generally it's quite a low percentage. So what you need to ensure is that within your own database, that people who are eligible for health assessments and also recalls are all detailed in a way so that that additional revenue can be done. Telehealth's been another area that's just come into being, and that's another area that medical practices now can continue to do. We know it's been extended for a short period, but it'd be interesting to see how it goes in the past. But what that will also allow people to do is for those patients that may not be able to attend the practice, then they've got another option that they can have a telehealth consult. And as an example, since COVID's been in, there's been over nearly 19,000 telehealth consults for GP practices. So it is a very high area that's been taken up. The next area and we've spoken about it, is just looking at operating costs and also utilising your consultancy rooms. If you've got a vacant consultancy room, there may be a way that you could actually utilise it in some other way, lease it out to somebody or use it in another way. But the consulting room should have a value, and you should be trying to ensure that it's always got somebody in there that's generating revenue for your organisation. The other 2 are just with regard to your practice incentive payments. Ensure that what you're doing there is you're doing the level of where you may, if you see more people with a chronic disease, you could receive an additional payment. If you did a lot of work just looking at your own throughput of people who have some of these chronic disease issues, then you may be able to generate new revenue. And the same thing with the workforce incentive program, which is generally funds for most practices their practice nurse. You just got to ensure that throughput is enough to generate revenue through that. And the last one, and Rod mentioned it, is that accessing grants. Most medical practices aren't that well at accessing grants, and that's an area that probably needs a bit more work to be done. So the next one, I only go through this because Rod and I did some work for an organisation in South Australia where they wanted to develop a primary healthcare service from scratch. So what we did with this organisation is we developed some different models for them, and the models were based on where they could receive their funding, and also about co-location of other services, and also arrangements with regard to leasing and contracting. And we developed 3 models. We developed one for a small model, a large model, and a larger model. As I said, it's probably not as relevant here today because of the group that's coming, but I'll just go through it and show the same thing, is that the most important part of any modelling is to get the financial part of it right. So with regard to the next part of the model, it showed that for a small practice, it's detailed the number of staff, and it's got the mix of those staff, and everything had a medical practice, and then you had mental health services, alcohol and drug, allied health, pathology, and also support staff. So what it showed there is it moves from a $2.5 million, $7 million organisation to over a $5 million organisation, depending on what it was. And the next part, what we worked out is that to house those people, what was the amount of space that we needed? As I said, it's probably not as relevant for this group, but if people are looking at developing a new medical service, or they're looking at expanding their existing services, they need to understand the costs associated with that expansion, including being able to have enough space to do that. So the next, I've finished my area, and we'll open up for some slides. Sorry, for some questions. So, not sure if there's any have got any questions at the moment. If not, then we'll just continue on with the next part of the presentation, where Rod's going to just talk about a bit more about primary health teams and so forth.
So there's no questions in the chat. Does anyone want to unmute themselves and ask a question to Rod or Chris?
That's fine, Tanya. We can just keep going. Yep.
Yep.
So, yeah, Chris has mentioned a lot of stuff on this slide already, but, you know, the diversification of funding options is really critical. If there are areas if there are funding out there that you're not accessing at the moment, then you're limiting your capacity to build your team. So that's important. And Chris has already mentioned some of this stuff. And while Chris has been focusing on medical practices, the whole area of allied health and mental health practitioners, and they require a provider number. So that's really important. What we find a lot in public sector services is the allied health staff and the mental health staff do not have a provider number. So, so Chris, are you going to show the provider number form? We thought a practical thing to do would be to show you actually the form, and we can send this out, Tanya, to people. So you can take this away with you or download it yourself. But it's a really simple process to get your staff signed up for a Medicare provider number. Chris, were you going to go through?
Yep, you stop sharing.
Okay, cool.
Sorry about that.
So yeah, maybe just while Chris is pulling that up, the one thing, if you take away anything from these sessions, is to take away the provider number form, because that provider number form will mean that you can give it to your allied health and mental health staff. And this is what the form looks like. Chris will quickly run through it. Yep.
So all the form is a form that your staff need to fill out to apply for a provider number, and it's got a list of all the professions that can use this form. So the form's quite self-explanatory, and so all you'd have to do, and I'll just slowly go through it, and as Rod said, we'll send it out. But there's actually, if you fill it out, and then just the service provider needs to be APRA registered, and then the rest of the details on that form. Once they become registered as a provider, what they then are able to do is then see clients who have had a GP management plan or a mental health plan and get funded through MBS. And how that works is, as we've said before, it will be based on some various rates. So what we would, as an example, if we go back to the slideshow, and I'll just keep working, sorry. So as this is just the area about using the MBS form. So the other thing too is that for your providers, there's different ways to structure the MBS payments for public providers. You need to make sure that it doesn't hinder any of your current funding requirements. And the other type of thing that you need to ensure is that how are the clients coming through the door. So in a lot of areas, and we often hear this term double dipping. So we've got to ensure that the clients that have been seen in a public environment are separated from those that may generally be seen as receiving services from that organisation. And also you need to ensure that the employment arrangements with your staff member are very well detailed. The other thing that you can do too is that it doesn't mean that you could have a staff member who works Monday and Tuesday, and on Wednesday, they could actually be working for you as a contractor seeing MBS funded people or people from or other patients funded in other different ways. So it doesn't mean that you need to provide the service yourself. It could also look at contracting that service out to an existing staff member if they're willing, if they weren't full-time at the moment, that they could actually provide that work as a part-time basis. This slide's a bit busy, but we mentioned all of it last time. This is just to do with regard to mental health, as we've got there that a GP can do a mental health plan, and based on that plan, a person can be seen up to 10 individual times, and that's been increased to 20 due to COVID. But in a 12 months period, they can be seen 10 times. Those payments can for different types of service providers, such as psychologists, social workers, and so forth. And that payment is based on the skills and the qualifications of that person. So as it's got there, generally for a 20-minute session, they will receive the smaller amount, but as the session grows, they would receive more. An example is that, as an example, if a psychologist saw a person for more than 50 minutes, they would receive a payment of just over $87. Whereas if they see a patient for under 20 minutes, they would get paid $62. So for a session that was at least 20 minutes. And that's one thing that you need to ensure that, and I'll be talking about this a bit later, is that you need to understand whether or not if you are employing that person, if you're generating enough revenue to actually fund that person. Now with regard to allied health, and we've got there again, if the GP does a GP management plan, then that person can be seen 5 times in the calendar year, and we know that that's not a lot of times, but it could also, those visits could be subsidised by some other types of funding that the organisation might have. And as it's got there, it's various services, and that they could be 5 different services or 5 of the same service, but they're able to have that 5. So if you're looking at having a community health centre as an example, and we mentioned that before, one of the questions that they could ask, or a public health, they would ask whether or not that person's got a GP management plan or require a GP management plan. And what could happen there is that they could be seen under 2 different funding streams, as long as they're separated and clearly identified by that organisation. And as it's got there, the MBS payment for this is $54.60 for a session that has to be at least 20 minutes. So with regard to that, so when you were looking at expanding your services and developing MBS type funded services, you need to understand all your own business arrangements as well. So as it's got there, you need to understand all these costs in employing a staff member, and also the costs associated with running your organisation. So the next slide just shows an example of costs to employ a person, and what all the modelling that we do, we generally allow $30,000 on top of the salary and on costs of a staff member to fund their employment costs. And that's the same for whether or not the staff member was a nurse or a social worker or an allied health worker or whatever. Because when you think about it, a person will generally generate the same level of infrastructure costs. They need an office, they need a computer, they need a telephone, they need the support by management and so on. So all the modelling that we do generally is we look at the salary costs to employ that person. You add the $30,000 onto it, and then what we would suggest is that that's the cost to totally employ that person. And the next slide just gives you some examples of that. So what this slide's showing, therefore, and this is where it's really important to understand the costs to employ a person, especially when you're looking at trying to generate revenue through whatever sources to fund that position. So as it's got there, if you're looking at a practice nurse or a podiatrist or an OT, if you're looking at the total cost of the nurse being $127,000 or podiatrist being $138,000, how is that position going to be funded if it's a full-time position, or even if it was a part of that position? So generally in a 12-month period, a person would generally be able to deliver about 1,300 direct service delivery hours. And what that's based on, that's the figure that's taken, that's left after you take out things like annual leave, long service leave, sick leave, and all those types of things. So as an example, if you're looking at the 1,300 hours of a nurse being able to work 1,300 hours, and they receive, and it's going to cost you $127,000, what that would mean is that for every that nurse would need to generate $100 an hour to fund their position, and a podiatrist would be a little bit more. So when you go back to our previous slide where we spoke about Mbs Funding receiving $54 for a 20-minute session, and you could probably do 2 sessions in an hour, that's $108. So it's very close to this type of funding model. But what that's saying is that you need to ensure that that person, for the whole 1,300 hours, sees an average of 2 people. And that's where some of the dilemma comes when you're looking at funding your positions. So as it's got there, the bottom one is you need to understand, does your revenue cover these costs? So you need to look at model. But one thing that we mentioned before is that a position there can be pools funding for a position. So therefore, a podiatrist doesn't need to be funded all through MBS or all through a Commonwealth grant or all through or NDIS or all through whatever. There can be a lot of ways to fund that position based on a range of different funding sources. And that's why, and I know that I've spoke about it a lot before, that's why the financial modelling is really important when you're looking at trying to employ that person. A lot of times most organisations don't actually know what it costs to employ a staff member. So that's the first thing that you need to understand, is that how much money do you need to receive to actually provide that service, or sorry, to fund that service. And the next area I'm talking about, and it's just with regard to looking at developing your business rules and your management reporting. And again, as I said, based on the people here, I won't dwell on this, and people need to read it in their own time. But what for a public organisation, a lot of them when you're looking at developing business rules, and that's mainly to do with how do they allocate overheads across programs. So there's a lot of costs in managing an organisation. So how do they actually allocate those costs across their staff members? A lot of organisations do it based on just a straight percentage, which generally isn't a true reflection on their cost. So generally what you'd need to do is look at that staff position and see what it costs to employ that person. How much admin time do they use? Do they need a motor vehicle? Do they need an IT? So it's a very detailed assessment of their needs. And the next area is just with regard to mainly to said public type organisations. They need to develop really good management and board reporting to ensure that they know what the costs are in running their organisation, and also develop some KPIs that would be able to assess how their performance are going. The next two slides, I'll just quickly go through them, but as I said, you'll be able to get a copy of this presentation so you can look at them. So the next one just shows some KPIs. So as an example, for a service provider or for a program, you can develop KPIs based on what they need to do. As it's got there, the number of consultations in a day, for instance, how much do they generate per consultation? And this is a mixture of KPIs for both GPs and other service providers. And this is just a report, so I won't dwell on that, because generally what you do when you're doing your board reporting is that you would try to link your financial requirements with your performance requirements. And what this report shows is that it shows how the program's going financially, and then it's also indicating a list of performance items and how they're going against those as well. All right, and now I'm back to Rod.
Thanks, Chris. So we're just about to finish. And so just to go back, I have to go to screen share again. Now I've gone to the wrong slide, so there you go. So we've talked a lot in these two sessions about some pretty boring stuff around financials and around, you know, how you can access different sources of funds. But so the summary is, you know, you really need to think about how people get into your service, because if they come in and they're not asked the right questions, and then your ability to assess their eligibility for different funding streams is really difficult. So, and you know, referrals from GPs are essential for MBS funded services. Your staff in the public sector, I don't think there's any excuse for a public sector provider not to have their staff on being able to access MBS, because it is entirely legitimate and you're entirely able to support to better deal with your waiting list if you have a provider number in the public sector. And equally, it helps with an integrated service model. So the connection with your GP. The GP will trust the public provider more if they know they can do a care plan and get an MBS funded service from the public provider. The same for NDIS providers. They can use the same kind of mechanisms. Becoming a health insurance provider is another opportunity. Accessing grants, as we've talked about, philanthropic trusts, and becoming an aged care provider. You know, there's opportunities for people to sign up to My Aged Care and start to access resources through My Aged Care. So there's opportunities there. So these are some of the sort of key messages. And the reasons we've dwelt on the financials is because fundamentally you can't have a strong service model without a strong financial model. And our observation is that some people do that fairly well, and some people don't do it well at all. So, you know, we focus on that really to build up your for you to grow your health service, not so you can have a bigger budget, but so you can better meet the needs of your community. So the takeaway messages from our sessions are that public and private primary health services are badly disconnected. There is no plan primary health care in Australia. The PHNs do a lot of the work to try and make the primary health system operate more effectively, but there is really no one out there going, hey, do it this way, do it that way. As I said, MBS is underutilised by most public health providers. Medical practice are not good at accessing grants that they could get, often on the basis that they don't have any space to put the staff if they got them. Our view is that can be addressed with careful financial planning. We haven't gone into that detail today because it's another whole story. Accessing MBS funding is not difficult. You know, get that form that we provided you with is really important. So assistance is available. Don't go away from this session and go, well, that was all kind of interesting, but you know, so what? What can I do? So the PHN have asked us to run these sessions. We've worked with a lot of providers in Gippsland and around Australia on how to set these services up and how to run them more efficiently. And a lot of that, as Chris has said, is understanding what the business looks like. Regrettably, or maybe not regrettably, you know, healthcare is a business. As we said in the first session, the total spend in Australia on healthcare is $180 billion. It's 10% of our total GDP is spent on healthcare. So there's money out there. Getting your hands on it is another trick, of course, but there is a lot of money out there. So the other challenge, I think, is if you know your community better than anyone else, you will know if there's parts of your community that are underserviced and under-resourced in terms of primary health care. There are opportunities for you, for your service and your organisation to expand into those communities using some of the funding formula, some of the tips that we've given you today. So again, we know from our work in Gippsland, and you know from your work in Gippsland, where there are those areas that could do with the establishment of a primary health service. Because primary health care is basically a market-driven activity, you know, the services tend to emerge once the market gets there. But, you know, there can be a big lapse between when a population needs a service and when the market is ready to respond. The PHNs and other government entities are in the business of trying to make sure that the system is not entirely dependent on the market. They're in the business of trying to mitigate market failure. So if you can see areas in Gippsland that you think that place really needs something to happen, then I'm sure the PHN and with our support would be happy to talk to you about what the options are for doing that. So I think, Tanya, we'll leave it there, and if there are no questions, that's fine.
I've got a question for you, Rod, from Sarah. Where a service already has a huge wait list, how can taking on further clients through MBS help to manage these wait lists without adding EFT?
Well, I think what we would say is that probably a whole lot of people on that wait list will qualify for a GP care plan. And so if they had a GP care plan, then accessing MBS dollars, if it's, say, allied health, if it's physio or podiatry or whatever, having a care plan from the GP would allow the provider to actually use Medicare MBS funding to assist them to get into their service. So if you're only relying on one form of funding, i.e. state government funding, then you're not using all the options that are available to you. I'm not saying that's easy, but, you know, there's a lot of examples of organisations that do that already. And we'd be happy to talk, you know, about how to set that up in individual services. Tanya, if that was helpful.
Okay. That's the only question I have. Anne?
Yeah, sorry, I dropped out and I probably missed some great words of wisdom there. So, and I apologise, but fixed my technical issue. And you may have touched on this, but we're all aware, you talked about those organisations or public funded organisations that actually lose money utilising Medicare. And an example of Headspace in the model of the various models that the Headspace lead agencies have adopted in getting GP involvement. And I think it is about the difference in expectation. Quite often the public funded services, community health, places like Headspace are saying they need long consultations. And it's not, and throughput is not as swift as it can be in a mainstream general practice. And there's not the short, sharp consultations, and it's really hard to make anything out of, you know, come out on top in Medicare with a series of very complex consultations. And so just your comment on employing a GP versus Medicare, and I know you did talk about the combination, but I think some organisations go into it Medicare only with a GP, and it just doesn't seem to work out.
No, it's a problem, and I think MBS, as you know, and is not a great funding tool for people who have really complex care needs. Mm. So I think, you know, we've done a lot of work with PHNs in this space. There obviously needs to be more of a blended funding tool for a GP working with, you know, people with significant mental health problems, because the MBS item numbers just don't cut it, you know, for that. So I think there's a challenge for the system, for the funders, to be able to say, well, yeah, we recognise that, and we do a lot of work in, you know, we're doing some work in Northern Territory at the moment, and it's clear that Medicare is not going to work in some of those remote rural areas. So a blended funding system with some, that's why we talk about getting grants. Don't just wait, don't just rely on Medicare to address the problems, but try and get pooled some funds. And, you know, I know it's sort of heresy these days, but, you know, supporting GPs with a blended funding model is clearly the answer in some service models. And Headspace would be one of them, but there's a lot of others as well. Medicare works well if you don't have a really serious problem. If you've got a serious problem, it's a problem.
And that's right. And that is the dilemma, because a lot of our community agencies are actually seeing very complex patients.
And that's why team care is so important, so that the GP can do the bit that the GP gets funded to do, but then works with other counsellors and other people to deal with ongoing more. So it's a question of what's GP work and what's not GP work as well. But the team care thing is really important. And often the solutions to these are at a micro level. So one Headspace might do pretty well, and another Headspace around the corner doesn't do it so well. So there's something going on in the way the micro operations of individual services work. Because some people do incredibly good work, and then you go down the road to another service and you go, well, these guys are not doing so well. What's going on? You know, and often it's in the minutiae of the operation of the service.
Yes, because you can have as you have said, an employ your GP, but also access Medicare, so that it comes to the organisation.
Yeah, and I think, you know, the PHNs and are partly, you know, this is an issue for the PHNs. We've spoken about with your PHN about the whole issue of double dipping and that stuff. Well, it's kind of like, does double dipping really matter if you're transparent about it and honest about it and straightforward and go, look, the only way we can do this is to actually pool some funds. So there's a great aversion to double dipping, which I totally get, but equally, you know, if people aren't totally ripping off the system, or, you know, at the end of the day, a client is getting a better service as a result of pooling those funds, I think that's something that really needs a lot of thinking through from the funders, from the PHM point of view.
Yeah. But you're right, there's a lot of, they get very nervous about double dipping, and some of the Headspace sites
Yeah.
do exactly that, but it's clearly can be done without it being double dipping.
But also with Headspace, and the service model is set up to double dip. It just encourages double dipping, you know, because of the way you've got the Medicare funded stuff alongside the grant funded stuff.
Yeah.
And it's kind of like, gee, you're making it hard. You make it hard for them not to double dip.
Yeah, no, it is difficult. And I agree with you. I think we've all got to be advocating, lobbying hard for the whole funding model for general practice to change.
Yeah.
And the patient, you know, medical home, whatever, that's got to be the right model.
And I think, you know, it's kind of like, from what we've seen in Gippsland, it's encouraging really strong, robust primary health services that already exist to also expand into other parts of Gippsland that actually are underserviced. And so I think that's a planning challenge for the system, is to, but you know, if you just wait for the market, then it's not going to, you know, it's going to be a long time for some of those areas to get the services they need. So I think that's it from us, Tanya. If there are no other questions, we can talk to Anne all afternoon. That'd be fine.
Oh, we would have much to say.
Oh, okay. Stories about Anne, don't you worry.
Okay, so there's no more questions that have come through, and I probably could sit and listen to you two for a long time, but I
could be one of the only people in Melbourne or in Gippsland that would.
So I'd like to thank everyone for joining us, and I'd especially like to thank you, Rod, and you, Chris, for both presentations. Now, your presentation slides will be available post this event, and they will come out to you with the surveys. So if you could kindly fill that in, that would be wonderful.
And Tanya, maybe just to reiterate, if people want, I'm happy to provide some very informal advice to people at no cost about how they can, you know, do some of this stuff, because I think it's, you know, I think it's really important so people who've got questions that they haven't asked.
Yep. How would you like that done, Rod?
Oh, they can just ring me.
Okay.
But however, you'll have our contact details.
Yes.
Somewhere, Tanya, won't you? So you'll forward that out. People can ring us or email us or whatever, but more than happy to have a chat, because I think people get very scared of the.
Yep.
But anyway, there you go. Be brave.
All right, so we will forward them out as well with the survey. So thank you, everyone, and I think we can close it off from here.
Cool. Thanks, Tanya.
Okay, thanks for that.
Okay. Thank you.
Goodbye.
Bye, Rod.
Bye.
Bye.